Now let's talk about foregut pathologies and hindgut pathologies. Now the foregut pathologies that we're going to talk about are hypertrophic pyloric stenosis, and we're also going to be talking about annular pancreas as well as pancreatic divism. Let's write these down. We're going to be talking about hypertrophic pyloric stenosis, annular pancreas, and pancreatic divism. And we're also going to be talking about a hindgut pathology named Hirschsprung's disease. Now, a hypertrophic pyloric stenosis is due to a hypertrophy of the inner circular muscular layer that is found in the muscular propria or the muscular externa within the intestinal wall. As a result of this hypertrophy, what is going to happen is the stomach, which is located here, and the duodenum, which is located here, the stomach is going to have trouble getting its contents into the duodenum. As a result, there is going to be an increase in pressure due to the buildup of stomach contents, and then that could result in vomiting. And this vomiting is important because stomach has acid inside, and if there is chronic vomiting from the stomach, what can happen is it can lead to metabolic alkalosis, which we see in these patients. What can also happen is hypokalemia, which we will talk about why. And as we're losing chloride, we're also going to get hypochloremia. It is important to know that the vomiting that occurs is not billious because we are not distal to the second part of the duodenum. So if we are distal to the second part of the duodenum, that is when we will see bilious vomiting. But since we are not there, here's the common bile duct. Since we're not there, we're not going to have any bile in our vomit. As a result of the vomiting, renin-angiotensin-aldosterone system is going to be activated, and with an increase in aldosterone is going to activate the sodium-potassium pump over here, the sodium and the potassium channels over here. It is also going to activate the hydrogen transporter over there in the alpha intercalated cells. So these are going to result in absorption of water through sodium reabsorption, and then potassium is going to be leaving. As a result, this is going to result in hypokalemia. Now let's talk about pathologies associated with the pancreas. Now, the pancreas has a dorsal pancreatic bud and a ventral pancreatic bud. What is important to know about the dorsal pancreatic bud is that it does not rotate during development. It just stays there. Whereas the ventral pancreatic bud is going to be the part of the pancreas that is going to be rotating. And then in the adult, it is going to become the uncinate process. What is important to know about the dorsal pancreatic bud is that in the future, it is going to give rise to the head, tail, and the body of the pancreas. The ventral pancreatic bud is going to give rise to the ventral pancreas as well as the main pancreatic duct. And in the adult, it is known as the uncinate process. So the ventral pancreatic bud, it is going to rotate around the duodenum to reach its final position. The two pancreatic abnormalities that we need to know about are annular pancreas as well as pancreatic divism. What is going to differentiate between these two disorders is that with annular pancreas, there is going to be malrotation of the ventral pancreatic bud. Right, so let's write that down, malrotation of the ventral pancreatic bud. As a result of this malrotation, what can happen is there could be a duodenal ring that can form, and this is going to constrict the duodenum, and there's going to be an increase in pressure, and in order to relieve that pressure, there's going to be vomiting that is going to be occurring. Okay, and this vomiting is non-billious because where it's not distal to the second part of the duodenum. So non-billious vomiting. Now with pancreatic divism, this rotation of the ventral pancreatic bud occurs, but in the adult, the dorsal pancreatic bud and the ventral pancreatic bud are not going to be united. All right, so they're divided, and that's why it is called divism. So the ventral and dorsal pancreatic bud are divided even though the dorsal or the ventral pancreatic bud has rotated. This is more common, and in most cases, pancreatic divism is asymptomatic, but it can sometimes lead to pancreatitis. But there's no vomiting. Now let's talk about spleen development. What is important about spleen development is that the spleen is not part of the dry tract, but it is going to receive its blood supply from the foregut. So the celiac trunk is going to supply our foregut, and that celiac trunk is going to give off a branch, a splenic artery, to supply the spleen. And what is important to know is that the spleen is going to develop from the mesoderm. And the spleen during embryological development, it is going to be an important site for hematopoiesis, and it is going to become a fully formed lymphatic organ by week 23. Now let's talk about a Hindgut pathology, Hirschsprung's disease. With Hirschsprung's disease, what is going to happen is there is going to be a error in the migration of neural crest cells. Neural crest cells give rise to ganglion cells, and these ganglion cells are important for relaxation of our muscles. So here we have the myenteric plexus, and the ganglion cells within are going to release nitric oxide to relax the inner muscular layer of the muscular propria and the outer muscular layer. If we don't have the ganglion cells, what is going to happen is those two muscles that we just talked about, the inner muscular layer and the outer muscular layer, are going to keep contracting. With this increase in contraction, it is going to be hard for passing stool. So there's going to be an increase in stool content within the colon, and this is going to result in abdominal distension. There's also going to be billious vomiting because we are going to be distal to the second part of the duodenum where the common bile duct is located. There's also going to be failure to pass meconium, and this makes sense as we just talked about because of the constant contraction of those two muscle layers. It is going to result in bowel backing up and not being able to be released. And another important information that you need to know about this disease is that during rectal examination, because of the manual relief in pressure, it is going to result in explosion of gas or stool during the digital exam of rectum. So during rectal examination with a manual relief in pressure is going to be resulting in an explosion of bowel and gas. And the treatment is bowel resection on the portion that is impacted, and the portion that is impacted the most is going to be the rectum. And the reason for this is that the defect in cranial column migration is going to result in the normally neural crest cells move caudally, inferiorly. So because the rectum is the last part of the GI tract, then these cells are going to be having trouble migrating the last, and as a result the rectum is going to be impacted the most.